Let's check. Okay. Can folks hear me? Yes. Okay. Good. Great.
A thumbs up if you can hear.
Thumbs up if we can hear, and we'll be sure. Fantastic. Okay. Thank you. All right. I'm gonna go ahead and get started. Okay, I'm gonna let you do the first one, and then I'll. Okay.
All right. So the first item on the agenda is the March 17th, 2020 minutes from the executive committee. We have a chance to review that. We do have that meeting. We needed to vote to approve the mental health and dental insurance renewal for our employees.
So as a reminder, that meeting was canceled, and we absolutely have to get the executive committee to vote on health insurance. Because we have to get everything together.
Minutes be accepted.
Okay. All right. And if there's any further discussion, I just want to point out that there was a typo in item B. The word solar, so you actually do SOE.
Yeah. Or feeling that I needed to talk about my soul at that moment.
Minutes be accepted as
But I've already stated here, but all right, all in favor, say aye.
Aye.
Any opposed? Passed. Next item on the agenda is the task. Commission item electronically for code 2.2-27822 A3 for the purpose to address the state of emergency. RIC's the operational response and continuity of operations.
Yes, so that's just a reminder, there's the code section that allows us to be able to do this, conduct this meeting virtually as a public meeting. The Attorney General made it clear to have legal guidance as well as these meetings can be conducted if there is discussion of operation of the crisis, as well as continuity of operations. So that's where we get into the review of the budget, some budget variances. So we won't be discussing our typical meeting agenda items today. And now, just to say to I'll go public comments. We did post on our website that public comment could be entered in email and be read into the record. This is similar to what the localities have been doing in this kind of situations. And as a little bit after 4, we did get any public comment.
Right, thank you. So the next item on the agenda is RCP operations review.
Yes, so in your packet, and I don't know, are we share screen?
We can.
Okay.
I'm sorry. Just a reminder, everybody, to speak very loudly or speak up so that people can hear, just to make sure that we're hearing it. So you need to share the screen.
So the RACSD in the packet operations during the state of emergency. I've shared many emails with the board through these last weeks. So this is a review, a fairly high-level review of what's been done today. I just wanted a little touch base of this to get in our meeting minutes. It's not all inclusive, but it gives you a timeline for historical purposes of decisions that were made and when they were made. As a reminder, it feels like March was decades ago, but it's really only been 2 months. Those first 2 weeks, the changes were happening by the hour, literally from morning to afternoon, from afternoon to evening, to middle of the night to morning, in terms of how we were operating. So some of the highlights that will be affecting us long term, certainly the state of emergency was issued. We suspended day support programs, RAI and Kenmore Club in person that following Monday. We began increased use of telehealth for outpatient services that Monday. Suspended all group therapy sessions. Enacted liberal leave policy. So as you know, we have typically 3 buckets of leave: annual, family, personal sick leave, and we adopted, we allowed for people to not have to worry about which lead bucket that falls into as we were figuring out the anxiety and concern and worry for employees. For our 24/7 programs and our residential 24/7 programs, we started increasing screening for COVID symptoms for individuals that were coming into the programs, as well as for employees. We reduced capacity of the Sunshine Lady House to 6 beds from 12 to allow for improved social distancing. It began operating as via telehealth on the 18th. On the 23rd, we went formally telehealth to the rest of the outpatient services. However, we have still need to do some in-person for injections, some medication administration treatment inductions. We have at least a clinician and an office person on site at all the clinics. So while the public in general, we request not to come in if somebody has an emergency, there's a protocol at each of the clinic where the techs and the admin staff invites them in and different steps. So we have not closed completely any clinic in the clinic. We suspended in-home case management services. We received allowance from the Department of Behavioral Health and the Department of Medical Assistance Service to allow for increased telephone and Zoom visits and regulations that were suspended during this time. We did have to do some layoffs, some furloughs where possible. We offered alternative positions as primarily, if not solely, in our day support programs that couldn't do day support weren't operating. Some folks were able to take advantage of some of those, some were not because of 7 and those situations may not have allowed them to be in residential settings. Those layoffs and furloughs also included transportation. We still are doing tax visits in the community to the extent possible, but we're doing them less and making sure that we have PPE. We started early April discussion of what would it look like if we had to have some program budget cuts, 5, 10, 15%, so getting ideas on people there. We were able to send, and throughout this, I've been in discussion with the Department of Health for ideas and my colleagues around the state, what they're doing. We were able to send some representatives to the N95 mask fitting in April. We got a donation from Salem Church, I think. Michelle, if you remember, through Phil Brown, through Mayor Washington Hospital, of some N95 masks for a fantastic godsend. So we do have those in-house. In the event we do have a positive person in a 24/7 program that offers protection. The juvenile drug court started resuming virtually in the end of April, again, not in person. We got allowance again from Medicaid and the department to have the MAP induction, so that's the Medicaid assisted treatment induction where individuals get their first dose, that can also happen virtually. You may remember before this started, we received a permanent supported housing grant from the state to be able to place individuals in their own apartments. That has continued. So that's, we continue to place people, so that's really exciting. So I cannot overemphasize how wonderful staff has been, how wonderful management team has been to manage our own anxieties and stressors in the midst of all this and to continue to provide services. Early on for our 24/7 program, we met with staff and not me, Steve or Joe met with staff, pulled staff aside, what's your comfort level in working with people, really talk to folks, and people didn't think in terms of what they needed to do to make sure that we were able to continue to provide the services. So, Myers Respite. Not for the individuals, the guidance more is to isolate them in place, so we're not taking them from one home out into the community somewhere else. It would be used as a place for staff to be able to go to, should they be working directly with somebody positive instead of going as a total.
Okay.
You know, even though as a state we're moving into phase one and some discussion, anxiety has not lessened among staff. Stressors certainly are still there. We are continuing all kinds of avenues to get personal protective equipment. We've been blessed with all kinds of cloth donations directly from Debbie. We have medical mask donations. We have all kinds of purchase requests out. Everything you read in the news about how difficult those things are to find is true, whether it's hand sanitizers and cleaning supplies to the 9 yards. So we continue to work on those. That does come at a cost, and that will impact our budget going forward. There is no doubt that the behavioral health needs of the community are going to increase as a result of this. That will be, we will see that in the coming future. Questions about just the operation of the community? In a bit, we're going to get into the budget and numbers, services, and those kinds of things. Any questions about a specific program?
I know that you can play yourself in front of us so that we actually, because I know you were sending us emails and keeping us informed, but summarizing it so that we saw this was wonderful.
We actually have been meeting, first we were meeting every day, and then 4 days, and then 3 days, and now 2, and keeping an ongoing spreadsheet. So we have about a 2-page spreadsheet that we made online. A, for historical purposes. B, early on, is one of us gets sick. What do we do?
Asking a question.
We'd like to. And
Some trouble with the sound, so I'm just moving my computer a little closer, so hopefully we can get it a little bit better.
Thank you. Do that or repeat the questions.
So if I stand closer to this, does that help it sound?
Do we need it? Can we get some mic?
When we tried it, it was a lot of feedback. So
Is the microphone here?
yeah, if you want to come closer, that'd be great.
I don't have a very loud voice. This presentation, the purpose of this is to review the known and the unknown impacts of the COVID-19 pandemic on our services and finances. Go ahead. The purpose of this slide is to remind you of our revenue sources for each of the 3 major program areas. The stay-at-home order had an immediate impact on our fee revenue, which is collected when we deliver a service and we bill the insurance company. Most of our services are normally delivered in person and on-site in our facilities. So this was disrupted by the stay-at-home order. The first column is our mental health program area. The majority of the funding for mental health, we need to pause.
Yeah, we'll pause 1 second. Hey, tell you what, why don't we have you? You were gonna call in, sir.
Okay, so this is our revenue by funding source for each of the 3 major programs. So the first one is our mental health program. The majority of the revenue for mental health is split 50-50 between state funding and fee revenue. And of those state funds, which is the blue section of the column, and the fees is the gray section of the column, about 64% of that state funding is restricted for specific purposes. Most of our mental health, most but not all of our mental health programs rely on a mixture of state funds and fee revenue in order to cover the cost of services. The second column is the developmental services program area, and that program area relies almost entirely on fee revenue to cover the cost. So, and we have two big programs in that area. We have our residential program. Well, they are at home, so they weren't really impacted, but our day support program was impacted. And then our substance abuse program area, which is the last little column on the right-hand side, the funding for our substance use disorder programs is mostly restricted, and it comes primarily from federal block grants and then state funding. So this program the substance use program suffers the least if there's a disruption in fee revenue. So fortunately, RACSB reacted very swiftly to modify service delivery. And Brandy's going to give you an update from an IT perspective of how we made that shift from in our facilities to telework and to telehealth.
So we had a very short amount of time to get up and running so that we could continue to provide services the best way we knew how. So we developed and implemented a plan to transition to virtual service delivery in less than 5 days, and we were up and going. Increased from the 10 Zoom licenses we had talked about earlier to we now have 80, all of which are HIPAA compliant. We had a little head start because we had already secured those 10 HIPAA compliant Zoom licenses, so we had all the paperwork and hoops jumped through already. That was an additional cost of about $15,000 for a year of these additional 70, so 80 total licenses. We are extremely grateful that we have since received a grant from the Community Foundation, which will cover the cost of these licenses, so that we had some community support to really help us with that pivot. We have also applied for several other grants, including the FCC has a grant out for telehealth and other grants just trying to support the pivot. So just to give you an idea of the impact for Zoom, in February we had 12 Zoom video meetings with a total of 38 participants. In March we had 915 video meetings with 2,586 participants. In April, we had 3,149 meetings with a total of 9,390 participants. So that's how fast the Zoom ramped up, program stepped up, and have really implemented. To support Zoom, where we don't need licenses, we have implemented Microsoft Teams, which is kind of for internal use for staff meetings and such to connect. It has a meetings feature, also a chat feature, and it's really worked well for staff so that we don't have to take up that HIPAA compliant license to have those such virtual meetings. We had to increase the number of users that are able to access our VPN, our virtual network, to keep things secure, from about 50 to about 250 who can access it at the same time. Again, we made sure that not only our services could be provided remotely, but if there was a need be that all administrative functions could also be provided remotely, including the billing and reimbursement and accounting purposes, which required a little extra setup because those processes take a lot of bandwidth. And so it was a lot easier to set them up with a different type of access rather than through just the VPN so that those processes could be faster. In addition, we had to add over 44 new telehealth billing codes across our programs, which included the setup of about 2,000 additional rules to make those codes work, both for billing purposes and state reporting purposes. So generally in 2019, the IT office closes about 630 tickets a month. In March, we closed 1,557 tickets, and again in April, 1,125 tickets. So we have been very busy. A lot of the equipment and needs we have repurposed things we had on hand to make it as cost effective as possible, but also get us to where we need to be.
to and place initially is see the start part. So, I do have a question about softball. Are the bill rates the same?
Currently they are. And that's one of the risks we'll talk about going forward as we move into the next phase. That's certainly a risk that if those rates change, that will hurt our people unless we're phased in back to in person. This slide and the next one shows the level of billable services from the beginning of the fiscal year through April for a select number of programs. So for each chart, if you start at the left, those are our billable services for the first month of the fiscal year, July, all the way through to April. Operations were relatively normal the first half of March before the stay-at-home order. But April was the first full month that the order was in effect. And I don't know what you would think would happen, but I was actually pretty surprised. Some of our programs, such as No Health Outpatient, which is at the top left, and No Health Case Management, which is at the bottom left, provided more services in April than any other month this fiscal year. And then programs such as No Health Emergency Services, which is at the top right, and the medical program, which is at the bottom right, provided less services in April than average for the earlier part of the year. And Jackie, if you can, if you could give the board an update on the experience of your staff and how they're delivering services in the switch to the telehealth.
Sure, yeah. So outpatient has definitely been very busy. We've seen utilization increase and no-shows decrease. Kind of one of the benefits of most people being home is that they are available for their appointments, and being able to provide telehealth has taken away barriers that might have existed, like transportation. And there's just an increased need, with people feeling increased depression from isolation or anxiety with worry about, becoming ill or, financial concerns. So we've definitely seen an increase in people reaching out to us to seek services, and then also increased engagement from our current clients. I think that, emergency services is down a little bit just because they, they're seeing crises in the emergency room, but people may be more reluctant to go to the emergency room. And also there's less other providers in the community providing services who might refer them. And then with medical, we just had a few medical staff who were on vacation in April who had pre-planned vacation and still took that time just to stay home. So that should kind of just be an anomaly and unrelated to COVID. But overall, everyone's just very busy, and they all jumped on board with telehealth, as Brandy said, very quickly, and are providing lots of services.
One of the things I will point out that Jackie had pointed out, Yolanda, all units are not created equal on this slide. So an emergency services unit is different than an outpatient unit in terms of time and provision. So just really, the best part about the slide is more trends.
Yes.
To what extent did you encounter situations where the person who needed services was not able to connect online?
Yeah, that does happen occasionally. And so we're able to use Zoom with video if people have a smartphone or they have, a computer and internet. But we're also able to provide the services by phone. If people don't have internet or a smartphone, we can provide therapy or a medical appointment over the phone. And we've kept the option open too, that if someone couldn't do either option, that they could still come to the clinic, and maybe they're Zooming with a doctor who's working off-site or from the clinic, or meeting with therapists. Emergency services is still seeing people face-to-face, and so is our medication-assisted treatment program as well. But most people either had a telephone where they could talk on the phone, or access to a smartphone or computer.
One of the regulatory changes was to allow for that telephone piece and not to have the visual.
Mm-hmm. Yeah, and for some people, they felt more comfortable at home, and they've made more progress in their therapy because they felt, able to kind of dig a little deeper in their home environment. Where for others, it may be more of a barrier, and there's certainly some clients, ready to see us in person again as soon as we're doing that.
Thank you.
Jackie, a question. Are there some that would prefer to continue the telehealth?
So Stephanie Terrell, our quality assurance director, her staff are doing a survey right now to ask people just that. And from what I've gathered, there are many people who really prefer telehealth and would love to continue with it. But a lot will just depend on whether we can continue to be reimbursed for it, because they've made special allowances for that during this crisis.
Thank you.
Some of our community support services programs. The programs reacted really fast to the situation, but the need to maintain social distance impacts the number of services some programs are able to provide. In the top left, it's psychosocial rehabilitation, or Kenmore Club. Crisis stabilization and DACE, which is at the top right, and day support, or AAI, at the bottom left. They all had to make adjustments to service delivery, which impacted the ability for them to provide the usual number of services. The day support RAI program, they actually provided more services than it shows in that chart on the bottom left. They closed the facilities before at home, and they started providing day support services to RACSB group home residents in their home. But we didn't know if we could get billed for that. So we didn't need as many staff, so there were layoffs. We're not servicing the people that live outside of RACSB facilities. We learned on Friday, however, that we will be able to bill for the services provided in the group homes, and that we will also be able to recoup some of the lost revenue for a time period through June 18th. So that's going to help a great deal with our AAI. And Joe will give you an update on the experience of the community support services programs and how they're operating.
Hello, everybody. Yeah, so all of our programs were affected one way or another, but more so the day programs, which had to close its doors. RAI, as Rhonda mentioned, had to make some adjustments. The good news is, and this goes for Kenmore Club or RAI, that we were still able to provide those services in a limited capacity. For RAI, out of the 171 members, we were able to continue to provide support for 61 of those folks in our group homes and our ICFs. And 9 of those are actually new enrollments, because those folks either worked or they attended other day programs, which ended. And so we were able to enroll them in our program, for now at least. But we're able to provide the service for RAI by transferring about half of the day support staff to residential to either provide the day services during the day and bill for it, which we learned we could do, thankfully, or to fill in vacant residential positions. And so they helped residential a lot by being able to do that. Kenmore Club, even though they closed the doors, they managed to continue to provide their psychosocial rehab services to all 90 members via telehealth. And we're able to capture about 80% of that service that we used to provide physically, which is pretty phenomenal. Transportation was also hit as a result of this, because the day programs were closed. Transportation that brought 58 riders to those 2 programs had to be suspended. Another closing, as Jane mentioned, the Myers Respite Group Home, which supported about 31 individuals. The good news is that the staff there, the 7 staff that work there, were able to be transferred to the DD residential programs and fill in open positions. Between RAI and Myers, they've actually filled 19 residential positions. And believe it or not, we still have 13 positions open, which is kind of hard to believe. So DD residential, as well as MH residential, continues to provide their normal services, if you want to call it normal. Another program that was impacted in a major way was our Sunshine Lady House, our mental health crisis stabilization program, when we reduced those beds in half from 12 to 6, and also put a hold on the 3 detox beds, which we just recently opened one of those up. And we did that due to some workforce challenges we experienced in March, and also in an effort to mitigate the risk. For example, just having 1 bed occupied per room. And we hope that, well, we expect in next month to start opening more beds as referrals start to increase. PACT continues to support their 70 individuals, mainly taking advantage of telehealth, but also providing physical supports by delivering medications, providing injections. We actually have 48 of those individuals who receive injections, bringing them food, assisting with lab work, etc. Our PED and infant case management program has gone completely to telehealth. They continue to support their 460 kids. There's some challenges with that. If you can imagine trying to provide occupational therapy or speech pathology through Zoom. Another challenge is we have some families who refuse to do telehealth. And of the 460, about 57 refuse to do telehealth currently. Another challenge is during this time, referrals have been down a little bit. But amazingly enough, right now our assessment schedule is currently full and we're getting about 2 to 3 referrals a day. Our DD support coordination program has also gone completely to telehealth, where they use Zoom and telephone, which is allowed. And the great news there is no family is refusing services, so they're able to bill 100% and provide 100% of services through telehealth, which means about 600 individuals per month are receiving service. And actually some of the individuals are enjoying seeing themselves on Zoom. And a lot of the families obviously enjoy the convenience. So that's pretty much it for community support services. If we didn't have telehealth really saved us, and we were really able to take full advantage of using that.
So if I just want to accentuate a couple things. Psychosocial rehab and the work that Amy and her staff have done, there are clubhouse programs around the state that are temporarily and maybe permanently going to be affected by this and not be operational. Amy was able to be creative and continue to provide that support services. And I have seen folks in the community that have been so grateful that they have some ability to connect with someone else through the clubhouse telehealth services. RAI, early on, the work that Lacey did and Steve did and Joe did to look individual by individual and what can we do, and look staff by staff, and what cohort can we put with what group home so there was some sense of familiarity with people. It's a lot of work to go into that. Early on, we were talking like March 17th, well, maybe we could take some people to the site and do something, and then at the 11th hour, I pulled the plug there and said, I can't do it. I just can't take that risk. We put staff in the group homes. Up until last Friday, did not know if we were going to be reimbursed for that. And we were talking about furloughs and layoffs. We decided as a team we couldn't do that. We couldn't pull those staff because of the need to provide the support, the need to impact, give folks a sense of comfort. So that was a risk that thankfully we're going to get a little bit of reprieve.
Yeah.
I wasn't so sure, but we were doing it anyway. So those are the kinds of decisions that are being made and going to continue to be made with management team and staff input along the way.
Any other questions for Joe? So 60% of our overall revenue comes from fees. So if we lose 5% of our fee revenue a month, that's a reduction of about $112,000. But so we've been talking about these since the meeting began. We immediately implemented some cost containment measures, such as the layoffs we just mentioned and the day support and transportation program, hiring freezes, postponing training, postponing travel. We're also saving on ways that were not planned, but just as a result, our staff are not traveling. So our mileage reimbursement that's usually $15,000 or so a month, it's like nothing right now. We're saving on fuel for the agency vehicles because people are not out and about. We're saving on cleaning those facilities that we spend $20,000 a month on cleaning all of our facilities. Those we aren't using, we're not cleaning. We're saving on utilities as well. We also, as Jim mentioned, closed my respite facility and the staff were redeployed, and that saves us money. Also because of my my respite facility operates at a loss anyway, so that saves some money.
I got a little ahead of you, sorry.
As I mentioned earlier, some programs operate primarily with restricted funding, and they don't rely very much on fee revenue. The total of the restricted programs is depicted with the green line, and this is a chart that starts at last June 2019 and goes through December. So the restricted programs, that's the green line. If there are no changes in state or federal funding, these programs should be okay through the end of the fiscal year, be okay through the end of December. And we don't anticipate that they will show a loss unless something changes with that restricted funding. Unfortunately, though, the profit or positive variance from those programs cannot be used in any other manner than by which they're prescribed. So we cannot use those funds to offset the losses in any of our programs that rely heavily on fee revenue to cover their costs. And that's the red line. The red line is the profit and loss of programs that rely heavily on fee revenue to cover the costs. So fortunately, we had a really good year up to the state of emergency stay-at-home order. So we had a nice buffer to be able to adjust to stay at home and switch to telehealth. And this will help us through the end of the fiscal year, which is June 30. However, if we continue to operate as we did in April, there will come a point, probably around September, that we won't have enough unrestricted funds to cover the cost. In that event, should that event occur, we'll have to either dip into our reserves to cover the cost of those programs or apply for a line of credit in anticipation of potential loss. So when I first put this together, I thought this is pretty conservative, assuming things are going to stay as they are in April. But now I actually think otherwise, because we heard this morning, that the Department of Health next door to us, they're closing several of their facilities because one person was ill. So imagine crisis stabilization if one staff person or one guest becomes ill, and we have to close the entire building for 2 weeks. We still have to pay the leave for that person. We're self-insured, we'll pay their health insurance costs. We still have to pay the utilities and everything in the building. So our costs aren't going to go down very much, and we'll have no way to make any fee revenue from that. Imagine, what does outpatient look like when we start phasing in reopening? Do we have to have an extra staff person to sit at the door to screen staff and clients as they come in? And what's the cost of that person and the cost of screening? Thermometers, are we handing out masks? Are we cleaning before and after? What does that cost look like? Big one, what if insurance companies stop paying for telehealth? We're going to have a phased opening, so everyone's not going to come back in at once. So we need to rely on telehealth to keep serving our employees. And if we stop getting paid at the rate we are now, that's going to have a substantial impact. So there are some scenarios that are actually more costly than what we're currently operating. So what do we know and what do we not know? We know now that we can expect, pretty certain, we can expect level funding from Stafford County. We know there's not going to be any new state funding. The Step Virginia process was going to continue and bring on new funding for new programs this fiscal year. We know that's not going to happen. And we know things change on a daily basis. As Jane mentioned earlier, went from meeting daily to 3 times a week to twice a week, but still there is something that changes every day that we have to consider. So what do we not know right now? We don't know what the local funding looks like from the remaining localities. We don't know if there will be any change in the state and federal funding that we rely on a normal basis. Hopefully we'll find out some of that next week. Again, I mentioned the telehealth services. We don't know what ongoing reimbursement rates are going to look like for that. We don't know what the total cost of personal protective equipment is going to look like, as well as cleaning supplies, the supplies we have to buy for screening individuals. We don't know the full cost if someone becomes infected. I mentioned we're self-insured, we pay health insurance claims. But if someone can't work and we're paying their leave and we have to grab someone else and pay them overtime to cover that shift, that increases the cost. What's the cost of opening with precautions? Again, what what do we have to do to our facilities so we can maintain a safe social distance and still provide services? That there's a cost to make changes in the facility. So a lot that we still don't know. So how do we cope with that? We are monitoring daily changes that are occurring and preparing for being able to deliver services in whatever change comes. We're reacting as we get more information, and then we just start that circle over and over. So that's a little of where we are, a summary, high-level summary of where we are now and where we might go. There's a handout, it has COVID-19 at the top, and that's a more detailed summary of what each program, how each program is likely to fare if our experience in April continues to the end of the
So we'll open up to questions, but before, we suspect that by mid-June, we will know from the local localities what their local funding is. Because everyone else in the country, everybody's schedule's off. So one of the nice things about Zoom and all these public meetings on Zoom, I've been watching a lot of local government meet, and it looks like about the week of June 9th is when the budgets are going to be final. So we'll know that then. And then the other thing, we are constantly on the lookout for state grants, federal grants, little bitty grants, anything to bring in resources to help. So that's the other piece that we do.
We've received from the Community Foundation grant, you mentioned the telehealth, $15,000, 2 small $2,500 grants. We've received a Medicare stimulus payment, I think it was $10,000, and we've applied for the next one, which I hope will be higher, but I haven't heard from that yet. A lot of the stimulus funding that you hear about in the news, we don't qualify for as an agency of local government. So we keep on the lookout for what we do qualify for.
There are, in terms of more federal dollars, and there's some SAMHSA grants that are rolling out that we're going to be applying for that will end up being one-time money. Right, but it comes through the state, it comes through the Department of Labor Health, they apply for it, and then they're grant it to CFPs. But we also know that the department in and of themselves are looking at like 5-15%.
The department collects information from us periodically on the cost of, what its cost is for personal protective equipment, telehealth, and what we project our costs to be for the next several months, 6 months or so, in hopes of maybe if there is any extra money that covers that kind of thing, the funding, but we don't know for certain.
Are you having a challenge in getting the protective?
Yes.
All the wipes and yes. So
Yes.
what are people? What are you doing?
Well, we have them now, and for 24/7 programs, especially, they keep a daily checklist and count of what do we have in our burn rate and what's available. And Joe's office has become sort of ground central for a lot of supplies, as has Steve. So we're making sure we allot them. I would say on average, correct me if I'm wrong, we're looking at about if we got nothing in tomorrow, which we are getting things in, so if we got nothing in tomorrow, we would have about an average of 4 weeks. Is that about right, Jeff?
I'm sorry, how many weeks did you say?
About an average of 4, thinking some have 3, some have 6.
Yep, that's right.
And people are coming out of the woodwork selling things, so we have to be a little careful too of kind of doing some due diligence and seeing if they're for real. So we had what we thought was a great contact from us. Actually, it has come back to a great contact. It's a woman who's just acting as a business, and she acts as a broker. And we're like, I don't know. We made some calls to her, some of her distributors and wholesale companies that she works with, and they said yes, she's legitimate. So I ordered one little box and passed, and they came in like in 2 days. So we have more making in. So, but yeah, people are coming out of everywhere that have everything. So it's,
You may have seen on Facebook, Chandler Pigeon, who's our human resources specialist, his parents in Florida who operate a pool supply installation company, had a connection with masks, medical masks, and KN95, not N95s, but KN95s, and donated like 1,000 of certain things, and it was just astounding because they had it and forgot to ship it. So.
I think Michelle in the, she got us hooked up with Bowman.
Oh, yes. Yes.
Here's Michelle.
Yeah. Michelle, you want to tell us about what we got from Bowman, other than the 500% proof? Sorry, I'm not
Bowman Distillery started, they converted their machines and started doing hand sanitizer and yes, high proof material. So we were able to get a couple cases of hand sanitizer as well as the cleaning spray donated to our agency on 2 occasions.
Things like N95 masks are still very hard to come by, so we're doing that. I remember K is like knockoff, N95 masks, but they still do offer some protection. We, at first I thought, so it was very hard to get things at first. Now we're seeing a little loosening up, but I think we're going to see it tighten up more when we go into reopening as people put precautions in place. I think we're going to have challenges for the next several months.
Question for Joe or sunshine wave house, are we looking at, we're at 6, are we looking at maybe putting that to 8?
We're actually at 7 now. As of last week, we opened up 1 medical detox. We're, for the next steps, we're working on the plans going forward, and we're looking at a gradual progress. They're at about a 91% occupancy, so they are having staffing challenges as well, and positive staff members.
A lot of the questions are very soft. Can you repeat the questions when you answer?
Sure. So Debbie just asked if Sunshine Lady House is going to increase bed census, and we're at 7 now, and we're at 6. We're probably going to look at 8 within the next month, but we are going to take it slow, especially in a program that is bringing folks in from the outside. Heather Honecker, if you remember, John Butler retired. Heather Honecker just sent in an email today. She got information around some testing that was available for folks prior to their coming in. So there's some opportunity there to make it a little bit more secure and mitigate risk. So the other question was about Western State, and state facilities are at about a 91% accuracy. I'm on a once-a-week call with leadership of the department and all CSB execs, and I believe facility-wise, there's maybe 12 to 13 staff that have tested positive in all the state facilities. I don't know which ones where, but their census remains high. But I do know they have roughly 1,000 vacancies of positions in state facilities that they're trying to fill.
Okay. Other questions? The next item again is still Rhonda.
We start our budget process in January, and it's very detailed. It's a line-by-line process. We get feedback from all of our programs on what changes they expect, what do they think the next year looks like. We put it all together. It's files and files and files of Excel workbook. We bring it to a public hearing, then we bring it to in May. So by the time the state of emergency was declared, we were about 3/4 of the way through the budget process and really not sure how to change it because we knew what some of the risks were, but we didn't know what the impact would be at that point. So this is a budget that we knew enough early on that one of our big changes that we usually make year to year is if it's feasible to do so, we usually put in our budget for a 2% staff increase at the beginning of July. It was early enough on to know that we needed to take that out. I'm not sure what other changes to make at that point. So I'm going to walk you through what the budget looks like and then tell you how we're going to take some things slow. So some things like training may be in the budget, but Jane has made clear we're not incurring that cost right now. Now, if things turn out in the next 6 months, if things are looking good and we're back on budget or where we normally are, then maybe that opens up in the second half of the year. So it's here in anticipation of things opening up, but it's with an eye that we've got to look at things closer anyway, but even more frequently. I want to thank Pam Hutchinson. She's our financial analyst, that she does all of the very, very detailed line by line analysis and putting everything together and getting the feedback. But we have a balanced budget. This shows you, so the revenue and the expense will be the same for the fiscal year 20 budget column and the fiscal year 2021 budget column. But this shows you on the left our revenue by program areas, our mental health, developmental services, substance use, and other program areas. Our other program areas consist of our transportation program, healthy families, and our early intervention or ARTC program. So if you look at the fiscal year 2021 budget column, you see that we have for our PC programs, our performance contract programs, the budget for our performance contract programs is $40.4 million, and for our other programs it's $6.2 million, for a total of $46.7 million. That's about a 3% increase from our 2020 budget, or $1.2 million increase from the 2020 budget. Now, I just said we're not putting in staff increases, so why is our budget 3% higher than last year? There's one piece that's missing here. Normally what we do is we say, here's the fiscal year 2020 budget, and here's what we forecast that we're going to end the year. And then we compare the budget and the forecast and put together our fiscal year 2021 budget. We don't have that forecast column in here now because that forecast was made 3 or 4 months ago, and it was no longer valid with what was going on now. So it's really as a comparison of budget to budget. So there's really not any new revenue. It's based on the forecast that we were putting together. We saw things are changing in our different program areas. So it's adjusted for changes that occurred during the year. So how we allocate our budget, the pie chart on the right shows you that. 43% of our budget is allocated to developmental services, 34% to mental health services, 9% to substance abuse services, and 14% to other programs. And next one. We are required to get your specific approval for the performance contract programs. So this chart shows you our sources of revenue and how we spend that money for each of the 3 major program areas for fiscal year 2021. So on the left-hand side is at the top of the chart is our revenue sources, state funding, local funding, fees, federal block grants, and other. And our other funding are federal block grants or restricted funding that we didn't spend in 1 year. It's generally restricted funding we didn't spend in 1 year that we carry forward to the next. So if you look under the mental health column, you'll see, as we talked about earlier, most of the funding from mental health comes from state and
No, they asked to come in, Rhonda. They might have gotten disconnected. They love it.
And then developmental services, you'll see that most of that funding comes from fee revenue. And substance use disorder, just as we talked about earlier, that funding kind of mostly comes from state funding, which is almost all restricted, and federal block grants, which is restricted. And the federal block grants, the federal fiscal year starts up 3 months later. If we don't use that money, then we have to return it. And if we don't use that money by the end of September, then we have to return it. The column, 2 columns on the end shows the variance from the prior year budget. This actually looks like we're expect to receive more local funding this year than last year. We actually do not anticipate that. Our fiscal year 2020 budget did not include, we put that together before we had information from all of our localities. So we actually expect level funding from our locality, or hope we get level funding. So how do we, so again, the chart on the right shows you our revenue sources. 67% comes from fee revenue. So again, when our fee revenue is disrupted, it can have a big impact depending on the program. 21% of our revenue comes from state funding sources, and again, a little over half of that is restricted for specific purposes. 3% comes from our localities, and 4% from federal grants. This is a cash basis budget, so it does not include accruals or depreciation. This chart should look familiar. It did not change from the chart you saw earlier when we did the COVID presentation. And again, it's just a visual. So we do not expect any change in our funding sources at this time. It's just a visual of the funding by program. Give you some information on our funding by locality. The donut graph on the top left are the number of individuals served the last complete fiscal year, which was 2019. There were 20,000 individuals served, over half from Spotsylvania and Stafford, and then Caroline, Plattsburgh, and King George. And those numbers are pretty close to where they were in 2018. There are some increases and a couple, I forget now which county had just a few individual decreases, but very, very similar to fiscal year 2018. The chart at the bottom shows you the contribution by locality for the past 4 years, and then that fiscal year 2021 is our request. We requested level funding. Looks a little different in Caroline County. We actually requested $117,000 last year in Caroline County, and we requested the same for fiscal year 2021. So even though we received the most funding from Spotsylvania and Stafford, the funding per capita is actually highest from Fredericksburg, followed by King George and
Or, inside the donut, is that 2019 or is that?
the fiscal year 2000.
Okay, that confused me. Yeah, so just a little comment.
Oh, yes.
Okay, thank you.
The next couple of charts give you a visual of the cost of programs by major program area. This is the cost of programs, or what we budgeted is the cost of the programs for our mental health program area. So you can see that most of the cost for mental health is an outpatient medical, which it's that's a very expensive, that's our psychiatrist and nursing, so that's a very expensive program to operate. Followed by our crisis stabilization or Sunshine Lady House, and then our outpatient programs. And the next slide. These are the costs, our budget for developmental services program. The intensive residential services are the most costly programs to operate. That's our group homes. Followed by our day support, our AAI program, and then our intermediate care facilities. The little bar you can hardly see on the very right-hand side of that chart is the supportive residential program. That program has one individual in it, and it costs more to support that individual than we can ever collect in fees. So we're considering alternatives for that one individual. And then our substance abuse services. Our budget primarily goes to our outpatient substance abuse program, followed by our medication-assisted treatment program. And the medication-assisted treatment program assumes that we're operating at full capacity. So how many people come in and follow through with that program. And then at this point, it's been up and down, but we budgeted for operating. And these are our other programs. Most of the other program budget is allocated to our early intervention or Part C programs, followed by healthy families and transportation. This slide is a breakdown of our expenses for the three major performance contract programs. The blue is, substance use disorder, developmental services, and mental health. The blue part of the bar is our budget for salaries. The orange part of the bar is our budget for fringe, which is our health insurance and payroll taxes, and then operating and administrative overhead. So as you can tell from the charts that most of our budget goes towards staffing, which makes sense. We're a service. So the budget includes a 6% increase in the health insurance premium. It does not include a salary increase for the beginning of the fiscal year as it normally does. We do have built in a 1% salary increase in January, but we'll evaluate to see if that still makes sense. There are a couple of new positions. Most of these positions were actually approved in the current fiscal year, but they were either approved like towards the end of the year or they weren't filled yet. So there is a full year of these positions included in the budget. And there's our sponsored placement program, our developmental services support coordination, 2 individuals there, a part-time prevention staff person, and 2 permanent supportive housing staff.
Those 2 permanent supportive housing staff have been hired.
Yes, yeah, so the, and most of, I think all of those were either approved already. They just weren't there for a full fiscal year. So you can go to the next slide. So what are our challenges? So I normally have on this slide state funding, federal funding, different things, but now our challenges are all around this pandemic and what it looks like for us and how we plan for that. So we put all of our capital projects on hold, including 601 Lafayette. We've implemented a salary freeze and we'll reevaluate in January whether it's feasible to do anything at that point. Training and conferences are built into the budget, but they're on hold until January 2021, and we'll reevaluate for that time. As I mentioned earlier, we're evaluating terminating the developmental services supported living program.
I'll jump in there. That is, if you remember historically, that we've had a budgetary challenge all along with that because it's one person. We've been keeping a license. Staff have been working to identify another service outside of our CSP that could support her. So that is a recommendation that we would bring forward, that we go ahead and give up that license for now. Doesn't mean we can't go back and get it at some point in time where it makes.
Marketing costs, we have a marketing budget. It was based on where we thought we were going this year, but all marketing costs will be evaluated on a case-by-case basis. We'll delay reopening the Myers respite facility until it makes sense to do so. And we'll evaluate the timing of restarting our transportation service. If we have to, we'll consider additional layoffs or furloughs if fees continue to decline or if there's a disruption in our federal block grant or state funding or for local funding. We have started and will continue to calculate the cost of reopening facilities and what that means and adjust the budget. Yes. We've just started to evaluate, like, well, they wanted 2 cases of toilet paper and that's a normal, but so that doesn't go on the list. But we do put masks, cleaning supplies that are above and beyond. Yeah.
Are you taking everyone's temperature? Not now.
The group homes do.
The group homes do, and only homes and house.
And our property.
Yes, we open. Staff to do that, even if it comes from another staff person to transferring that position, to me, that's a little bit
Yeah.
expensive, it'd be nice to get track on that. So,
Mhm. I agree. Our transportation, our property maintenance department, they're also taking their temperatures daily, so that when they're at a group home, and then you choose the facilities, they can go in any of the facilities, they'll go to an issue, but it tells you. Oh,
I could do one.
I can-
And we can do something.
the,
Right over here.
but it tells you how our group home staff are being very careful and diligent about who comes into the facilities, and checking to make sure everyone's well.
So, a couple things that need from the board, certainly answer any questions, but this is a draft discussion of the budget. We are looking at, for requirement, a public hearing for the budget on June 16th. So we'll have more information on local and state dollars, and then we would bring to the board the adoption of the budget at our June meeting. Depending on the situation, it may happen like we are now, or it may be in person. So are there other things you'd like us to consider in terms of 21 reductions or holds or those kinds of things? You know, to repeat, we put capital projects on hold, including Lafayette Boulevard. I anticipate we won't be looking at that again until FY 2022. In the event we need to dip into our reserves to keep our services. I think it's a blessing that we didn't sign any debt service or any loan right now, so we're not paying off any loan for development. But it, you know, it's a delay. It's not a stop. But we're not having to pay off any additional loan.
Any work that needs to be done there?
There is not any immediate work. So
The
interesting.
building's not gonna fall.
Right. The roof got patched, and the lean-to part of the brick building got taken down by Todd and people. So yeah, there's nothing, and the lawn maintenance, we've actually brought that's one of these lessons. We brought property maintenance in-house. So we were able to use some staff that were laid off or furloughed to those positions. Some weren't able to do that, so they're not ongoing. But we anticipate at some point to be able to hire individuals through a MICA work program and a Chem Work Club program to help work with Todd and his team as lead specialists. That will save money with some of the big property folks and be still able to be held to the CSP standard. So that's kind of so we're going to still be sure we keep that clean and tidy and whatnot.
this was the greenhouse resolved, but we couldn't contact somebody to take it.
The individuals that expressed interest have all declined to take it, so we're going to use it to grow flowers for the group.
Which for them.
The one that's at 601 Lafayette.
Yeah. Right. But sort of to that end too, if there other capital projects will be approved relative to health and safety. Somebody needs approved, if the floor needs to be fixed, so, you know, those kinds of things. Yeah, what happens, exactly. Other thoughts or questions, please?
We have a handout that's a detail by program of the budget. Just for your reference.
I don't know if there's anybody on Zoom that wants to ask any board member in terms of any additional input. I can tell you we've been bantering about salary reductions. You know, some localities are doing that, and we landed on a no. I think it's important to say there may be additional layoffs or furloughs depending on things. We just don't know. So those additional furloughs or layoffs would likely be non-revenue producing positions that we look to in terms of furloughs. A lot of my colleagues have been doing week furloughs here and there with various staff and addressing things that.
There's some feedback going through. I'm just trying to make sure this all works.
Any board members with other questions or comments on Zoom, or any staff that would like to make any additional comments or questions?
Yes, I'm just trying to look through here and see what are the ones with the largest. The other version from the supportive housing, they're all over 60%.
Okay, yeah, glad you
So I
mentioned.
guess you have justification for those.
Yes, jail diversion, if we don't use all of, that's for restricted funding, we cannot use it for anything else. So if we don't use that, then we carry it forward. So that's the anticipated, that increase is the anticipated carryover from this year. Permanent supportive housing is a new program that started, actually, it's only been a couple of months, actually. So that's a lot of restrictive funding that will carry over into next year.
So the 680K for FY20 is not for the whole year.
Right.
So, and
there's a- the decreases are largely due to funding that we one-time fund. If there are any decreases, it's generally due to funding that we received this year that was one-time funding that we have not built in to receive next year. Our inpatient program that shows a 26% decline, that was based on the forecast. We had initially budgeted $268,000. We just did not spend that as much as we budgeted this year. So the fiscal year 2021 budget is based on our actual experience this year.
That's lifeless, right?
Yes, and that's reimbursed. We pay for like the Snowden Hospital, and then we send our invoice to the fiscal agent, and they reimburse us for those expenses.
So that's where we're paying folks that are uninsured who need up to 4 days of inpatient hospitalization. And we've seen in our region a lesser having used that pot of money less because of Medicaid expansion. People have Medicaid expansion. So we've got to pass it.
Noticing that it's such negative variance with Kenmore Club, how much of that is because of the conversion online?
And oh, can you see that? Oh, in the
You mean the employment?
the employment services, and then we just received really late. We received a one-time, well, we don't know if it's going to be one-time, and Joe may actually have more information, but we received this really neat program, a grant to develop an employment program for individuals. And so Amy Gendra at Kenmore Club is spearheading that, and it will eventually be open to both mental health and developmental disability individuals. So the grant was to get it up and running and to get a plan. So it's training, it's developing a program, and then I believe the process is then she goes back and here's the program, and then hopefully more funding is forthcoming.
So what you're looking at, Karen, it was in the FY 2020 because it's one-time money. It's not in the 2021. So it was a grant that we received that we said we wanted to do. And Amy and I actually had a call. We're getting technical assistance through a state process for that. with our ultimate goal of being a provider under the Department of Aging and Rehab Services, be able to provide extra employment services, which would be kind of where we're wanting to go in general. It's the different avenues to do that. Provide employment.
Well, and that is a relatively small amount of money in the total budget. I guess the other biggest reduction, if I'm reading it right, because it's a little fuzzy, kind of small here on my screen, looks like supervised residential services. Is that where?
Yeah, and so it's really not a reduction in the budget. That Kenmore Employment Services, that was added on as a grant. So that came late, one time only, so that it disappears in FY 21. We're not taking anything away with that. That's being spent. The other bigger one is the under mental health supported residential services, and that's something we're going to have to watch month by month. If you remember, prior to COVID, we were being concerned with the NCOs authorizing services appropriately under that program, what that looks like. So,
And that the mental health residential programs used to receive a lot of discharge assistance planning funds. It was funneled through the CSB. That's all changed in how those funds are distributed. So we had planned for a lot more in fiscal year 2020 that actually did not materialize. So we made that adjustment in fiscal year 2021 budget. We also used to receive a discharge assistance planning funds that were specifically for our Bridgewater facility, and we no longer receive those funds as well. So there's less funding in the support in the mental health residential service. So Myers is actually in our supervised residential services. That's how we report it to the state. So
I don't know if you heard that question on the call. Debbie was asking where Myers goes in terms of performance contract, and it falls under supervised residential.
And that looks like a big decrease, but that was based on number of individuals in each of the programs and the payment reimbursement timing. Our let me get the programs. Our supervised residential services, just the timing of in fiscal year 2020, the timing of our last Medicaid payment made that a little higher. So that was all incorporated into fiscal year 2020. So it's more normalized budget. Yes.
Any other questions? That will move on to next step.
Yes, so a one pager here to talk about what we're talking about. It's really where we are in terms of working on guidance to return to what operations should look like. I think a couple of important things to remember is certainly what's going to guide us is availability of personal protective equipment for staff at all levels of programming. Continued review of information from the health district and any other thing there is to read, we read. Chamber of Commerce today for Fredericksburg area published a wonderful document. I think that also talks about step one is to continue to learn about what's going on. So we're going to continue to be aware of what those look like and the governor's executive order. We are going to be informed by payer sources. Something recent from GMAS has said they would give us at least a 30-day, and I'm calling it a runway, that they'll give us 30-day notice before that goes away. I've heard everything on calls from 30 to 90 days to 18 months of telehealth allowance. So all those pieces are into the mix. But we've been talking pretty much since April, how do we put this back together again? And we need to put it back together again. And what opportunities we have to make things look good in a more efficient way. So I've asked staff to provide something in writing to me that they're collecting from staff by tomorrow with ideas, and I will put that all together. And it's Friday. We're going to have further discussion. Long story short, we're going to tweak it and feedback and give it back to staff with I say finalized guidance, but that's not true because it's too fluid. But some sense of guidance by the end of this time of what does that progression look like. Adding beds to Sunshine Lady House when we need to. We're envisioning staggering shifts of staff in the admin and reimbursement, for example. Not having all financial staff come back in at the same time. We're envisioning checking temperatures at the door, having one entry site, doing staff screenings, Terry's been collecting employee screenings that are being used. The VACSB is sharing protocols and plans from other boards. As you can imagine, other parts of the state that have been hit differently have different things to consider about. We're in a wonderful situation where we have Northern Virginia and Richmond and smack dab in the middle. So mine tends to go cautious. Any other questions about that or things that we
What's the normal length of stay?
7 to 8 days is normal, but they can stay at 50.
So, and then we expected to have proposed program.
No. So Sunshine Lady House, if we have a positive case, we would look to track, do a whole staff listing and tracking up there. We may have to quarantine people in their rooms and get tested.
So that was my question.
Yeah. Right. So we would, and probably not take people in, or we take people in a certain way. We would look to Department of Health. For our outpatient programs with people that are coming in by chance, today got notice that the social services had a health nurse, Department of Health nurse, test positive, who's not assigned to social services, but because she was there, they're closing for deep clean. We may have to consider that. But because we're providing the service telehealth, we should be able to continue to provide the service even though we're not on site.
Having the buildings cleaned, is that increase? Or is it?
Our building?
Yes.
It has not.
In Sunshine Lady House?
Yeah. So Sunshine Lady House and our 24/7 programs are, yes, increasing, like they're cleaning. We have decreased, like the day support side on some of our clinics. We're not cleaning those folks, so there's nobody there. So we're saving some on cleaning contracts that way.
And what do you see as a trend for communities' mental health?
So
have you, I know that
sure.
Jackie already said that they were having people with anxiety and calls, but
So Linda, for folks on Zoom, can you check the back page out?
Absolutely.
So Linda asked what we see as the trend in the community. Two things. One, because we're on the emergency room platform, we can see who is currently receiving services who end up in the emergency room now. And we're seeing that percentage. Tomorrow I'm on a call with representatives of United Way, Washington Healthcare, Stafford government to start talking about a post-pandemic plan. in terms of support for community, because all signs is that.
Yes.
So, yeah. So that is, so Nancy mentioned that the alternative transports are way down, which has been interesting. Can't figure out why exactly, but our Sunshine Lady Watch referrals have been way down. Even though we're decreased, we're having a hard time even people who are sick. So
Is that because people are getting percent telehealth and that's sufficient?
So yeah, and we keep, you know, ES, well, some of it, Jackie, jump in if you need, some of it we've discovered folks that need detox a little bit and then mental health, and if we're not providing the detox, they can't access the service. So that's a little bit, some of it is just be aware, people being frightened to go to the emergency room. I equate it with that, being frightened to come out.
Yeah, I do think there's some reluctance for people to leave their home and go to a residential program.
We're still needing the CMT at the hospital, correct?
So Jackie, she asked, Debbie asked if we're still maintaining CIT at the hospital.
We are, yes. We haven't had any trouble filling our CIT officer shifts at the hospital. They've been signing up for those, and we're still able to take custody at our assessment site. The hospital did ask that our peer not be present just because they were trying to limit the number of people in the ER, but the officer is still there and we're still able to take custody. And our emergency services staff are conducting the assessments via Zoom, just to limit their exposure to you know, any COVID cases that might be in the ER.
We're seeing the same numbers.
The same numbers for the CIT. I think that there was a little bit of a drop at first, but things have been picking up recently as far as the number of pre-screens that they're conducting.
I know we had to use Western State as a last resort admission higher in April than we did in March. I think it's in 11 people.
That sounds right.
So.
I guess I just have another comment or two. Once you read experts, you know, the second or third wave in the fall and follow on. You know, vaccine mutates, so ours is mutates. Even if a vaccine is developed, a flu vaccine, you know, this year was over 30% effective. So, you know, we're still going to see COVID cases in the future. So, I see telehealth continuing. It's going to be necessary. So it is a good thing, right? Right now, the rates are what they are. But the rates reduce, we're going to have to find a way to make it still profitable.
Yes.
Right? So,
Yes.
because I think telehealth is huge.
Yeah, I agree.
And it ought to be a sort of a foundational part of what we provide.
Yes. and I think depending on when and how the rates reduce may mean we have to make some harder decisions in other programs, because we'll need to provide some foundational performance contract, what we do for the community services, and keep people safe. So.
But it may also be an opportunity for us to find, you know, medical staff who don't necessarily want to live here, but we still provide services for us.
One of the, so Matt was saying this may be an opportunity for staffing to provide service as well. One of the variances that is in place now is reciprocity for licenses across state lines didn't exist before. So yeah, to that end, who can we access?
So that ought to be part of what we, RACSB, we go to EACSB and try to get, you know, I guess, lobbying bill for telehealth,
Yeah.
you know, national, right? So
Yeah, how can we do that? State legislators, and I can get you language, contact your state representatives, that serve you, Joshua Cole and whatnot.
Is there any data collection being done right now to support the continuation going on?
Like a,
Or even if it's just like surveys from individuals, something that we can.
We started a survey here, some agencies started a survey, but there's not that much data. Everybody's still worried about staying afloat. It's too much into the outcomes of it. But one of the meetings was on, at some point, there's going to be a lot of requests for that kind of thing. What have been the actual outcomes of the process? Our people doing. So we're slicing and dicing. Yeah, to the extent, yeah, to the extent that we can, we are doing that survey and making those calls.
And if we could execute,
Yes, I think
That would be-
that's a great idea.
really,
Yeah. The well, but I think as board members to make contact, I'd be happy to get.
I'm just really astounded by the amount of work the staff has done during this time, and all the diligence and time. As you're saying, it's changing minute by minute, and I hats off to you. For the work
oh. My husband doesn't know that. I agree with what everyone has said, and really, I thank you and the entire staff, all your management staff, all the employees. I even understand you're trying to reach out to previous clients, and I just think the things that we are doing is really, really incredible. And I'm not really sure this is over. So whatever we can do to be prepared, I gotta find some things. It's really bugging me. And thank you all. Thank you. Thank you, Terry. Thank you, everybody.
Yeah, that's a compliment to say that. I think staff transfers would like, even if they're not in those. I was working, came up. I think everybody else should be very proud. I'm proud of them. We all.
I will, and yeah, truly, and these guys did it, and from some of the spreadsheets that Joe's staff with residential, incredibly humbling to see, like, individuals who could tolerate being masked, individuals who couldn't tolerate being masked, what the impact of all of it is, and constantly looking at it, and nobody blinked. So I appreciate that. So very humbled by it. There's 29. What is it?
Yeah, speak up. He's getting some feedback, so.
about 30 altogether with the layoffs and
I think it's 20, with the layoffs and the furloughs, it's 30. So, and part-time and full-time.
It's approximately 28 that are laid off right now and 5 full-time furloughs.
Reverend Davies?
I just want to join the others in commending the staff on the splendid job that you've done during this challenging time. And I don't know if we're going to talk about raises.
We're not January. We're not having reductions.
We have checks.
But you really have done an outstanding. You really have done a noteworthy job. These are challenges. Honored to the challenge. Thank you.
And nice to see you.
One more thing. You still have board members to check in with there. Linda, you got anything?
Linda Carter. Linda Carter, anything to add?
No, I don't have anything, but hi, everybody.
Susan, do you have any questions, anything to add?
Remember, there's about a minute delay. There's some delay.
She's not.
Susan Gale, anything to add?
No, I've had a hard time this whole time. It's been difficult to hear a lot of people.
Sorry.
Somebody maybe called my name. I've had a terrible time hearing about the last 20 minutes, but I did hear Reverend Davies and that he was congratulating and complimenting the staff, and I absolutely second that. Jane's been great about forwarding all sorts of praise along with all her other information for the last couple of months. But these presentations, this information really brings it home. It's very impressive, and I'm very appreciative.
Yeah.
I am assuming, was it me, Kia?
Yeah.
It's all good. No, I just wanted to echo the same thing. I am extremely proud of RECSB, all of the work that you have done. This has not been easy, I know, and I couldn't be more proud to be associated with a better group. So thank you.
I can add, just for the record, so that we get to the minute, because it is related to operations, and we'll talk about it when we have a regular board meeting. But I sent out, I know, information on the work that Amy Ginger did to get 38,000 pounds of food into the planning district. Just astounding. And it was because she had a connection with church, she had a connection with the loading dock, and then worked with all food security supplies, and it was just astounding. So just for the record, to acknowledge that community partnership really very fun.
Becky, you got one more question?
I wanted to say what a lovely facility this is, and except for being cold, it was really absolutely beautiful, very pleasant, and I enjoyed being here.
Good. So we may very well have a meeting again here.
It's just lovely.
Okay. And the last to speak, I just want everybody's comments, taking it all in. It's exactly how I feel. The staff, Jane's management, leadership, and the connections with FEMA, CEHS, CACSB, people that you connect with, even for the directors of CSBs, just keeping us rolling. This is so hard, and I just can't understand that. And I don't know how that can happen, but you are. And so thank you very much. We are adjourned.
Thank you all.
We have to do that next time.
Thank you
Figure out.
for making all that happen. Well, I think the sound was good.
Let's just do it by-